So welcome to the class. Today's topic is guidelines on the post-exposure prophylaxis, that is PEP for varicella or shingles. This is updated in January 2023. So we begin with our quote, Master MRCOG with concept-oriented clarity. This particular guideline is going to be very, very important because you will have EMQs from this particular guideline. Okay. So what are the high-risk groups? So the high-risk groups are the immunocompromised individuals, pregnant women, and neonates. Okay. So three things: immunosuppressed individuals, pregnant women, and neonates. These groups can develop severe or life-threatening varicella with complications such as pneumonitis. Okay. So what is the purpose of PEP, that is post-exposure prophylaxis, is to reduce the disease severity and the risk of complication. It is not intended to completely prevent the infection. So the post-exposure prophylaxis is not intended for prevention, complete prevention of infection, but it is meant to reduce the severity and risk of complications. So traditionally, if you see the older guideline, the medicine which was used, or the drug which was a varicella zoster immunoglobulin. Historically, it was used for PEP. Okay, but what was the problem with that? There was a national shortage of varicella zoster immunoglobulin due to manufacturing issues, and UK Health Security Agency, that is UKHSA, formerly it was called as PHE, they reviewed the alternatives. And what were the interim measures which were suggested? VZIG, that is varicella zoster immunoglobulin, reserved for the most vulnerable where antivirals were not suitable. Okay, and antiviral oral is recommended as an alternative for immunosuppressed contacts and pregnant women from 20 weeks of gestation onwards. Okay, so here comes the role of antivirals as a PEP. Okay, initially it was VZIG, but there were logistic issues, and hence it was decided that antivirals are comparable efficacy is there. So the use for immunosuppressed contacts and the pregnant women from 20 week onwards. Okay, so updated recommendation from 2023 is antivirals are recommended for PEP in all at-risk groups except susceptible neonates exposed within 1 week of delivery. Okay, either in utero or post delivery. So just remember, antivirals are recommended for PEP in all risk groups except within 1 week of the delivery. Okay, and VZIG, varicella zoster immunoglobulin, remains the recommended only when oral antivirals are contraindicated. Okay, so next topic is a post-exposure risk assessment. Okay, does the person need PEP? This is the most important question, whether this patient requires PEP or not. So which factors we need to take into account to decide the post-exposure prophylaxis? So there are criteria for recommending post-exposure prophylaxis. The PEP is required only if all three criteria are met. Okay, significant exposure to the chickenpox, that is varicella, or shingles, that is zoster, during the infectious period. So listen this carefully. There has to be significant exposure. Okay, so this significant exposure to the chickenpox or shingles during the infectious period. So we should know the infectious period, and we should also know the infectious period for the chickenpox, and we should also know the infectious period for the shingles, and we should also know whether it is significant or not. Okay, and second is a high risk individual. Which are high risk individuals? Just now we have seen immunosuppressed neonates and the pregnant women, and no antibodies to varicella zoster virus, which is confirmed by the urgent testing within 24 hours if needed. So you carry out this antibody testing, and if the antibodies are negative, then you go ahead with the PEP. So all these three criteria, there has to be significant exposure to the varicella and or zoster during the infectious period. The person should be a high risk individual, and there should be no antibody to varicella zoster virus. Okay, so let's see about this chickenpox and shingles and their infectious period. So regarding the chickenpox, the transmission route is inhalation of the aerosols, direct contact with the vesical fluid, and respiratory secretions. And what about the infectious period? It differs for immunocompetent person and immunosuppressed person. Okay, so the infectious person period for immunocompetent person is 24 hours before the rash and 5 days after the rash. Okay, So the person is infectious 24 hours before the onset of the rash and 5 days after the rash, provided the person is immunocompetent. If the person is immunosuppressed, then he or she will be infectious 24 hours before the onset of the rash until all lesions are crusted. Okay, so these immunosuppressed patients are infectious till the crusting of all lesions, while immunocompetent persons 24 hours before the onset of the rash and 5 days after the rash. Okay, now coming to the single, okay, or zoster. So mainly transmission is mainly direct contact with the vesical fluid, and in immunosuppressed it may get transmitted via respiratory secretions also, and infectious period is from the onset of the rash until all lesions are crusted. Okay, so did you see the difference between the chickenpox and the shingles in the infectious period?
Yes, sir. One is 24 hours before the onset of rash, and zoster is since the onset of the rash.
Right. And this also differs from immunocompetent and immunosuppressed person. Okay, so it will be infectious till 5 days after the rash, and this will be till all lesions are crusted. Okay, so this is the most important thing, because they'll give you the scenario and you have to identify whether the person is immunocompetent, means index case is immunocompetent, immunosuppressed, and what kind of exposure is this. Okay, whether that exposure is in the infectious period or not. Then next, it will also depend upon the type of varicella zoster virus infection in the index case. Okay, so contact with the chickenpox, contact with disseminated shingles case, contact with immunocompetent individual with exposed shingles. Okay, read this carefully. Contact with the immunocompetent individual with the exposed shingle lesions such as ophthalmic shingles. Okay, so when you are looking at the index case, and if it is a shingles and the person is immunocompetent, then it should be in the exposed area such as ophthalmic shingles. Okay, but if the person is immunosuppressed, in that case, any localized shingles has got a viral shedding. Okay, so these are the patients cases which require a PEP. So one, with respect to the chickenpox, any contact with the chickenpox in the infectious period. With respect to shingles, if it is a disseminated shingles case, or if the index case is immunocompetent, then if the lesion is in the exposed area such as ophthalmic shingles. Okay, and if the if the contact is immunosuppressed, then individuals with localized shingles have an increased viral loading. So contact with immunocompetent individual with non-exposed shingles such as thoracolumbar lesions, PEP is not indicated. So they generally ask you this in the SBA. This SBA will be in the first 10 SBAs of your paper, especially in paper 1. That which has got a highest risk of infection. So the ophthalmic shingles, because it is in the exposed area. Okay, while thoracolumbar is a non-exposed area, the PEP is not indicated in immunocompetent person. But if it is in the immunosuppressed, then any localized shingles will be having increased viral shedding, so PEP is indicated. Is this clear to all of you? Is this clear?
Yes, sir. Yes,
yeah.
yes.
Okay, so this is going to be important. Now coming to the timing of exposure. If it is a continuous exposure with the index case, such as a household, the index case is in the household only, or nursery, or care worker, so PEP is indicated. There may be multiple exposure with the index case during the infectious period. This can happen with any case. Okay, then single exposure within the infectious period. Okay, single exposure within the infectious period, that is for, we have just seen what is the infectious period for chickenpox, that is 24 hours before the onset of the rash and 5 days after in immunocompetent person, and until lesions are crusted in immunosuppressed patients, while shingles from the onset of the rash until lesions are crusted. Okay, so in this case single exposure will also require PEP. So there may be continuous exposure, there may be multiple exposure during the infectious period, or there may be single exposure within the infectious period. Okay, now in which cases the PEP is not, if the exposure is outside the infectious period, PEP is not indicated. Now closeness and duration of the contact. Okay, suppose where it is indicated, if it is a household contact, then same small room for more than 15 minutes. Okay, in the same room, if there is a contact more than 15 minutes, this is called as significant exposure. Okay, so you have to identify whether the exposure is a significant or not. Okay, and if it is a face-to-face contact, again conversation level, that much contact, PEP is indicated. And in immunosuppressed contacts, in open wards also, the risk of airborne spread, especially in pediatrics, is known. Okay, so in all these cases, the PEP is indicated. Okay, brief or casual contact, no direct or close exposure, PEP is not indicated. So what is the, if you are given a scenario, please see what is the scenarios is saying. What is the duration, where it was, what was the duration. Okay, so you identify and then you have to decide regarding the PEP. Okay, that is why I have kept a separate slide to, so that you can understand it well. Okay. Now coming to the assessment of the susceptibility, what we have seen is in which cases it is indicated, in which cases it is not indicated. But from the patient point of view, whether the candidate or that particular person is susceptible or not, that also we should be able to find out. So there is no benefit of varicella zoster immunoglobulin if the patient already has adequate antibodies. Okay, if there is IgG, VZG, IgG is positive, then there is no benefit of immunoglobulins. Okay, for immunocompetent person, including pregnant women, if there is a history of chickenpox, shingles, or 2 vaccine doses. Okay, suppose the person is immunocompetent and already has got a history of chickenpox, shingles, or already vaccinated, then the person is not susceptible for the infection. Okay, but if there is no such history, okay, then what we have to do? We have to do the antibody testing. Okay, so this there is a history is not sure about the previous infection. What? Okay, if there is no history, then we will have to do the antibody testing on the booking sample. Okay, and post-exposure prophylaxis is required if the immunoglobulin level is less than, antibody level is less than 100 milli international unit. Okay, remember this particular figure because it is different for immunosuppressed person and it is different for women. Okay, so if there is clear-cut history, then PEP is not required. If there is no history, then we will do the antibody testing. Okay, and if the antibody testing is negative or less than 100 milli international units, so this is quantitative. Okay, if it is a qualitative negative, then also PEP is required. If it is a quantitative less than 100 milli international units, this immunoglobulin is PEP is required. Okay, the person is immunosuppressed. Okay, in that particular case, reliable. Okay, always go for antibody testing. So this was for the immunocompetent, including the women. Suppressed patient, the history of infection, vaccination, always test antibody. Please unmute yourself. Okay, history of infection, vaccine, not always go for. And if the person will be said to be immune if antibody level is more than or equal to 150 international units. Okay, and if the levels are less than 150, then PEP is required. Is it clear? The levels of antibody and where the significance of the chickenpox infection, shingles,
Yes.
in immunocompetent persons, but in immunosuppressed, that is not reliable. Okay. So this is what about the assessment of the susceptibility. Then coming to the types of post-exposure prophylaxis. Now, recently in the first slide only, we have seen there are 2 types. Previously it was VZIG, okay, varicella zoster immunoglobulin. Now it has shifted to the antivirals. So first we will discuss about the antivirals. So antiviral, there are 2 antivirals, acyclovir and the valvacyclovir. Okay, first line PEP is given for 1 susceptible immunosuppressed individuals, all susceptible pregnant women, any stage, and high risk infants. Okay, so this first line PEP is required for susceptible immunosuppressed individuals, all susceptible pregnant women, and high risk infants. when it should be started. Okay, now listen carefully. So the start day is from 7 to 14 days after the exposure, and it is to be continued for 7 days. Okay, so when it should be started, if there is exposure, then it will be started 7 days after the exposure, and it will be continued for the 7 days. Okay, and this can be started up to 14 days of the exposure. Okay, it should be started after the 7 days, but can be started up to 14 days, and it is to be continued for the 7 days. Okay, the exposure day is the rash onset of the rash in cases of household contact, and in cases of non-household contact, the first contact will be considered as the day of exposure. Okay, if the person is presenting after day 7, a 7 days course can still be given up to the day 14. Okay, so ideal treatment we should start at 7 days and continue for 7 days. But if the person reports, or if the lady reports after 7 days, then also this 7-day course can be given up to day 14. Okay, is it clear? The PEP?
Yes.
Yeah. Okay.
Yes, sir.
Then why it should be started at day 7? So it has been seen that starting acyclovir immediately after exposure, there is a higher infection rate, almost 77%. Okay, versus starting on day 7, the infection rate is, means in spite of giving PEP, then also infection can happen, but this infection rate was higher if it started immediately. It was less, 21%, if it started on day 7. Okay, so this is what is the difference, and that is why we should start at day 7. Okay. Just a moment. There is some issue. Okay. Yeah. Then what is the drug of choice? Acyclovir is a standard option. Okay. Valvacyclovir is preferred in some cases due to the better bioavailability and fewer dosing. Okay, and better tolerance. So you have acyclovir and valvacyclovir. The valvacyclovir is the dosing schedule is preferred. Okay. Less number of doses are required in valvacyclovir. Side effects are dizziness, headache, GI upset, nausea, vomiting, diarrhea, skin rash, pruritus, photosensitivity, urticaria, fatigue. So these are the side effects. Then what are the precautions? Renal impairment, malabsorption needs the adjustment of the doses of acyclovir, and VZIG may be considered. Okay, and VZIG only if seronegative, antibody level less than 150 in cases of immunosuppressed, or less than 100 milli international units in pregnant women. Okay, urgent cases, qualitative antibody testing is acceptable. Now, recommended oral antiviral doses are: for infants 10 milligram per kg 4 times a day. For children 10 milligram per kg, maximum is 800 milligram QID oral acyclovir. And for adults, remember 800 milligram QID 4 times 800 milligram. So this is the dose which is given for PEP. Okay, so PEP dose is different, and the dose for treatment or therapeutic dose is different. So oral acyclovir for adult, it is 800 milligram QID given for 7 days. If it is a valvacyclovir, then it is not indicated in infants. But after 2 years, it can be given in a dose of 20 milligram per kg. Maximum is 1000 TID, and for adults, it is a 1000 milligram TID. So this is only the dosing, if you see, is more convenient with the valvacyclovir. Okay. So special note is that individuals on long-term prophylaxis, such as the patients who are on hematopoietic stem cell transplant and all, they may require temporary dose escalation to the above treatment levels. Then licensing, not licensed. This drug actually not licensed for PEP, but widely used for chickenpox treatment. Okay, but off-label prescribing is allowed if it is in the patient's best interest and supported by evidence. So you need to talk to the patient and tell that this is beneficial, so can be used. Okay, so always inform the patient, then use. Repeat exposure: if the person is re-exposed, then the further antiviral PEP courses can be started 7 days after the second exposure. So if there is a second exposure, again start second dose after the 7 days. Okay. Now coming to the second PEP. So second variety is a human varicella zoster immunoglobulin. So for whom it is indicated? It is indicated for individuals unable to take oral antivirals, and for susceptible neonates exposed within 1 week of the delivery. Okay, so this is the thing which you should always remember. The role of VZ, previously this was the preferred. Now, because of the logistic issues, they have shifted to antiviral. But still, where is the role? One, if the person is not able to take oral antivirals, and second, up to neonates up to 1 week of activity. Then what is the preparation supply? Prepared from pooled plasma, non-UK donors by Bioproducts Limited. It is supplied in 250 milligram vials. Okay, the doses is, these are the doses. Okay, below 5 years it is 250 milligrams, 6 to 10 years it is 500, for adults it is 1000. Okay, 11 to 14 is 750 milligrams. How it is given? It is given deep intramuscular injection. Divide the doses if the volume is more than 3 ml in young children or more than 5 ml in older, and neonates and infants, injection site is upper outer buttocks. Okay, what should be the timing? Ideally within 10 days of exposure, but for immunosuppressed and neonates it should be given within 7 days. Exposure day, we have already seen, it is the rash of onset in cases of household, and it is the first contact in cases of non-household. Okay, if there is a second exposure occurs beyond 7 days, or in cases of immunosuppressed within after 7 days, then we have to reassess for the need for the repeat PEP. Okay, special note is that individuals on regular IVIG, they will not require VZIG if the last dose is taken within 3 weeks of the before the exposure. So if the person for any reason is on immunoglobulin therapy, and if the last dose of immunoglobulin is given within 3 weeks, then VZIG is not required. Okay, so the VZIG, where exactly the role is, I hope it is clear to you. Okay. So what is the guidance for specific groups? There are only 2 groups. One is an immunosuppressed. Basically, there will be 3 groups: immunosuppressed group, pregnant women, and the neonates. Okay. Now, immunosuppressed individuals. All immunosuppressed individuals are at a risk of severe chickenpox and must be assessed after exposure. Efficacy: varicella zoster immunoglobulin reduces severity, but not always fully protective. Acyclovir and valacyclovir shown to be as effective as immunoglobulins. Breakthrough infections reported, but usually mild to moderate. Okay, so acyclovir has got a strong safety profile, and immunoglobulin, VZIG immunoglobulin carries low, but still the risk is present as similar to the blood product. Okay, so RCPCH guidelines says both antivirals as well as VZIG can be given, but UK now they prefer antivirals. Since 2018, they are preferring the antivirals only. If chickenpox develops in spite of PEP, if PEP is given, but still there is a chickenpox, then what to do? The prophylactic dose, you will convert it into therapeutic dose. Okay, so therapeutic dose we'll see soon. So start therapeutic antiviral dose immediately, and if it is a severe disease, admission and IV acyclovir is required. So in cases of severe disease, hospitalization and IV acyclovir. If the patient is stable, then therapeutic dose is required. Okay, which is different from the PEP dose. Okay, if there is a second exposure, reassess the patient. Repeat risk assessment, like what we have seen. What is the duration of exposure? Whether it is in the infectious period or not. Okay, that you will reassess, and then antibody recheck before further prophylaxis. If exposure follows closely after antiviral course, repeat antiviral starting 7 days post exposure. So if the exposure follows closely after the antiviral dose, we will be repeating antivirals after the 7 days. Okay, and if there is an inadvertent vaccination, if immunosuppressed patient receives live vaccine or shingles vaccine, urgent assessment is required and start antivirals if susceptible. Okay, if there is an inadvertent vaccination with a live chickenpox or shingle vaccine, urgent assessment and antivirals are to be started. Then second category is the pregnant contacts. So what is the risk in pregnancy? Suppose there is an exposure to the varicella zoster and the pregnancy is less than 20 weeks. Then there is a risk of fetal varicella syndrome. Okay, but in latter pregnancy, what is the risk? One, there can be severe maternal infection and there can be neonatal varicella. So neonatal varicella is different and fetal varicella syndrome is different. Okay, so in late pregnancy, there is a severe maternal disease and there is the possibility of neonatal varicella if the exposure is near the delivery. So what is the rationale for PEP? It will reduce the maternal infection severity and it will reduce the fetal and neonatal infection risk. Safety, we have 2 options, VZIG and acyclovir or valacyclovir. VZIG is safe, but it will have the same risk as a blood product. Acyclovir and valacyclovir not licensed in the pregnancy, but large studies show safety, no increase in the birth defects. So efficacy of immunoglobulin is suboptimal. Around 40% will develop chickenpox. Okay, so equally effective is acyclovir, and hence it is preferred. So go for acyclovir. Okay, so it is equally effective, preferred, well tolerated, easier access. So risk assessment: if there is a history of chickenpox or shingles or 2 doses received by the mother, she is immune, no PEP is required. Okay, this also we have seen. If the history is uncertain or there is no history, what we will do? We will test for immunoglobulin. This is the SBA which is the most commonly asked. They'll give you the scenario, and if there is no history, then you will do the testing. You will find out the antibody level, okay, from the booking blood. If it is more than or equal to 100 million international, that means she is immune. Then no PEP is required. If she is less, value is less than 100, she is susceptible. Then you will treat. Okay. Then recommended PEP dose we have seen: acyclovir 800 milligram 4 times a day to be started on day 7, given for 7 days there onwards. Alternative is a valacyclovir 1000 3 times a day. Okay, same duration. And VZIG only if unable to take oral antivirals. Okay, if exposure is after the day 7, then still it can be given up to day 14. Okay. Now, if chickenpox develops during the pregnancy, then what we will do? You will switch to the therapeutic dose. And what is the therapeutic dose? 800 milligram 5 times a day, or valacyclovir 1000 milligram 3 times a day for 7 days. Okay, so here is the difference. So the PEP was 800 milligram 4 times a day, but the therapeutic dose is 800 milligram 5 times a day for 7 days. Okay, and in severe cases you will give IV acyclovir. If there is a second exposure, you will repeat the risk assessment and consider another course. Okay, inadvertent vaccination we have seen. If it is a live chickenpox or shingles, in that particular case, you will assess the immune status and monitor the mother. If it is a non-live vaccine, then there is no risk and no action is required, and report all inadvertent vaccination in pregnancy to UK Health Security Agency vaccine in pregnancy surveillance. Okay, so you need to inform to the UK Health Service security agents. Okay, same thing is given here in tabular form. High risk of immunosuppressed individuals are at high risk of severe chickenpox and complications. A routine assessment is required after significant exposure. For pregnant women less than 20 weeks, there is a risk of fetal varicella syndrome that is identified as a microcephaly, limb defects, and scarring. Okay, so these are the typical features of fetal varicella syndrome. Okay, then in later pregnancy, there is a risk of severe maternal disease and neonatal varicella if the exposure is near to the delivery. What is the recommended PEP in immunosuppressed individuals, and what is the recommended PEP in pregnant women? The first choice is oral antivirals. Here also first choice is oral antivirals. Dose is same. Okay. Then alternative is varicella zoster immunoglobulin. Here also alternative is valacyclovir can be given, or VZIG only if unable to take antivirals. Otherwise, this is the first choice. This is the alternative, and this only if these oral antivirals cannot be taken. Okay. Then what is the efficacy of PEP? VZIG reduces severity but not always protective in immunosuppressed. Antivirals at least as effective as VZIG. Breakthrough infections are mild to moderate. Here in pregnancy, VZIG is suboptimal. Almost 40% will develop chickenpox. And antivirals are as effective as VZIG, and they are preferred due to the safety and convenience. Okay. Treatment: if infection develops, you will be starting in immunosuppressed, you will be starting therapeutic antivirals immediately. In severe cases, hospitalization plus acyclovir. Same thing here in severe cases, hospitalization plus acyclovir, and switch to the therapeutic dose. And therapeutic dose we have seen it is 5 times. Okay, 800 milligram 5 times, and there it was 800 milligram 4 times as for PEP. Okay. Handling repeat exposure: reassess risk after each exposure, repeat varicella zoster antibody test if possible, and if new exposure soon after antiviral course, repeat antiviral starting 7 days post exposure. Okay. In pregnant lady also, you have to repeat risk assessment and antibody test. If second exposure soon after antiviral course, repeat antiviral from day 7 of a new exposure. Okay. And if there is inadvertent vaccination in cases of pregnancy, if it is a non-live vaccine, then there is no risk, no action is required. If it is a live access, you will report to the UK Health Security Agency, assess the immune status and monitor the lady. Okay, and report all cases of inadvertent vaccination in pregnancy. Okay. Now coming to the infant and neonates, and here comes the role of VZIG, because up to 7 days VZIG is required. Okay. Now risk assessment in infants and neonates. Highest risk is to the neonates in the first week of life. These will lead to high life-threatening complications. Risk depends on the maternal antibodies, prematurity, timing of exposure, and hospitalization. No PEP is required if the newborn is after 7 days after the maternal chickenpox. If the mother is having the chickenpox, the baby is born after 7 days of the maternal infection, then there is no PEP required. Okay, so this particular duration also you need to remember, and you need to read the scenario carefully for this. Okay, and if there is a maternal shingles before or after delivery, the antibodies are protective, because the mother, this shingles is a reactivation of the primary infection in the mother. So if it is a maternal shingles either before or after delivery, then PEP is not required. But if the mother has a chicken pox and the baby is delivered within 7 days, then the PEP will be required. But if it is developed after 7 days, chicken pox, then PEP is not required, because the antibodies will be protective in that particular case. So PEP indications, they are divided into 3 groups. Okay, group 1 are the neonates of mothers with chicken pox, not shingles. Okay, 7 days before and 7 days after the delivery. Okay, so these are the neonates born to the mother with chicken pox and deliver 7 days before or 7 days after the delivery. So action is to give VZIG within 7 days. Okay, so it is within 7 days the baby is delivered. Okay, within plus minus 7 days of chickenpox the baby is delivered. So here in these cases VZIG immunoglobulin is required. Okay, if maternal infection is 4 days before and 2 days after the delivery, then add a IV acyclovir 10 milligram per kg 3 times a day, 10 days. Okay, due to the highest fetal risk. Okay, is this group 1 clear to you? Here there is a maternal chickenpox infection, but the delivery is within 7 days. Okay, so
Yes, sir.
is required is a varicella zoster immunoglobulin. Okay, but if it is within 4 days before or 2 days after the delivery, then IV acyclovir is to be added along with this. Okay. Then coming to the group 2. Group 2 are the infants less than 1 year who are born before 28 weeks or less than 1000 gram at birth, or there is a severe congenital or underlying illness needing the prolonged care. So they may give you the scenario that the baby is born preterm and the baby is in the hospital in the NICU, and the mother has developed infection or something like that, and then we need the infant PEP. Okay, so action here is a test infant varicella zoster antibody. So group 1, what we did, it was directly we have given the immunoglobulin. Okay, here you will test it. If the infant is more than 4 week old, then we will give oral acyclovir. Okay, as usual, will be started 7 days after the exposure and will be continued for 7 days. Okay, provided the infant is 4 week, more than 4 weeks. If the infant is less than 4 week old and the antibody is negative, in that particular case, immunoglobulins are preferred. Okay, so for group 2, we have 2 options: antiviral and varicella zoster immunoglobulin. If the infant is more than 4 weeks, go for acyclovir. If it is less than 4 weeks, the antibody is negative, go for varicella zoster immunoglobulin. So here action is test infant varicella zoster antibody. Okay, so what is the action in group 2? Test infant varicella zoster antibody, depending upon then weeks of after the delivery or the age, we are going to decide either oral acyclovir or the VZIG. Then group 3 are the neonates which are exposed to the chickenpox or shingles, but not from the mother. They are exposed. So here the maternal antibodies will not be protective. We do not know about the mother. There is exposure from the outside in the first 7 days of life. Then in that particular case, what we have to do, we have to test the mother. Preferred is a mother. Other alternative is the infant antibody. Okay, and if the antibody is negative, then varicella zoster immunoglobulin is to be given. Is this clear? Group 3 is clear to you? If the baby is exposed, there is a difference between the group 1 and group 2. Both are within 7 days. Here there is a infection from the outside, not from the mother. Okay. In that particular case, we will test the mother or the infant for the antibody. If the antibody is negative, then we will give the varicella zoster immunoglobulin. Okay.
Excuse me, sir. So previously for pregnant women, the cutoff value for antibody was taken as 100. Here it is mentioned as 150.
Yes. Here they have given 150. So, and there it was a 100.
100.
And here we are talking about the, see, here this antibody level is going to be the passive protection for the baby, no?
Okay, so for babies, we are considering 150.
Here, no. This antibody is a maternal antibody only.
Okay.
Or the infant antibody also they have, but preferred is a maternal antibody. You got it?
Yes, sir.
Because baby will be protected passively, no?
Yes, sir.
So this you have to remember. Here it is a 150 international units, okay, milli international units. Then you will give varicella zoster immunoglobulin. Okay. The next is determining the immune status. So group 2 infants may lack maternal. These are premature infants, so they may lack maternal antibodies because of prematurity, transfusions, etc. So we have to test the infant. So in group 2, always test the infant. Okay. In group 2, always test the infant. Okay. In group 3, preferred is a mother. Okay. In group 3 infants, if the mother has a definitive chickenpox or shingle, no testing is required. Okay. If mother is vaccinated or uncertain history, then the test mother or the infant, and the cutoff is less than 150 international units. It is susceptible and give immunoglobulin. Okay. So in group 3, if the mother definitely has a chickenpox or shingles, then testing is not required. Is it clear? Here they are saying that test the mother, but when there is a mother is vaccinated or uncertain history, then the test mother or the infant. But if there is a definite history, you don't need a testing. Okay, and these are the cutoffs. Okay. Special note is discharge. Sometimes this scenario they can ask you. Okay, the mother is delivery, everything is fine and all. There is a discharge. She is due for the discharge today, but the elder kid is having the chickenpox at home. Okay, then discharge home is safe if the mother is immune, even if household cases exist. Okay, but if the mother is susceptible, avoid contact until the neonate is more than 7 days old. Okay, so if the mother is immune, in that particular case, the mother can be discharged. The option will be many options. They'll do not discharge for 7 days or whatever it is. But if the mother is immune, then she can be discharged. Okay. Repeat risk assessment needed for group 2 infants with subsequent exposure in the hospital, and treatment if chickenpox develops. So this is the treatment. If in spite of all this, if the neonate develops chickenpox, then the dose is 20 milligram per kg IV or cyclovir every 8 hours for 7 days. Okay. So this is the for the neonates. Okay. That finishes the first topic of varicella zoster.